here, your best friend is going to be you have to go to the library and download the free book. Oh, where's my maternal? Nursing Made Easy, okay? So, I can pull stuff from your PowerPoints. I can pull stuff from the workbook I put on there. I can pull stuff from Lippincott Advisor. I can pull stuff from Nursing, and I can pull stuff from here. Because I have told you that these are all of your resources. So don't ignore this book on the library. Everybody understand? Your sexuality. Don't freak out about that. It's self-study. Look at your PowerPoints. Your STIs, you can find in Lippincott Advisor. We're not going super in depth with that. I will review that next week so that you kind of, but we're kind of very general. Like for erectile dysfunction, what are our risk factors? What do we do to treat it? If we are treating it, then if a man comes into the emergency room with heart attack symptoms, what do we need to know if they've been we need to know if they've been taking a medicine for erectile dysfunction, okay? Those types of things, very basic. Somebody going through menopause or perimenopause, what are we worried about? What happens to your bones? Osteoporosis. What are they going to take? And vitamin D. Very basic, okay? So basically, what does it do? Why do we worry about it in that population of people? What are our interventions and or education? Very basic, okay? That's why it's self-study, and we're not going to eat up a lot of time with that in class, okay? STIs, don't go down the rabbit trail of knowing every single drug that treats them. If it is viral, some of them have an antiviral medication. If it's bacterial, what are we giving them? Antibiotics. The majority of them are covered by penicillins. Not all of them, most of them. You're not going to be the one prescribing, okay? So just know, if it's a bacterial, we're gonna be able to cover it. Kind of know, is it curable, is it not curable? Okay? There's one on there that there is a vaccine for. Kind of know those types of things. Know which ones go together. So a lot of times if they have gonorrhea, they're going to have chlamydia. We're going to put our friends together. Know what you're going to educate the patient on. They need to complete their full treatment. They need to abstain for sex while they're being treated. All of their partners have to be tested. That type of thing. Don't go down the rabbit trail of knowing every single med that treats STIs. You're not prescribing them. The doctor's going to prescribe that, or the nurse practitioner. You're the educator. Deal? Okay. Because most of those things are outpatient. So here we go. So I come in. I've called the office. I've said that I think I'm pregnant. They tell me to come in. And we're starting from like the very beginning, okay? So usually when you come into a doctor's office, what are they going to ask you? Patient demographics, okay? So I'm 37. That's my birthday. I'm Caucasian and I'm married. So very basic patient demographics.
Do we have this somewhere?
No, this is my case study.
Oh, okay. I was trying to find the case.
Nope. All right. What's the next thing you want to know about me? You know my age. You know my date of birth. So you kind of have some identifiers. You know that I'm married. Are you allergic to anything? Who said? Think of Big Herb. Who said medical history? There we go. All right. My medical history. I'm not allergic to any drugs. My past medical history, or however you want to say it, I have migraines, I have asthma, I have hypothyroidism. My previous surgical history, I've had my ACL really replaced, not repaired, in my right knee. A laparoscopic myomectomy in 2013. So a myomectomy is the fancy word to take uterine fibroids out. Because they're called uterine myomas. So there you go. I had a C-section in 2014, and then I had a knee scope in 2020. Currently, I take levothyroxine. What do I take that for? Here we go. And albuterol as needed for my asthma. What else do we need to know? drug, there are no known drug allergies. So we will need to know my last known period, but what else do y'all think is important to know? You can see here, I've had a C-section, so that tells you what? I need you to know how many pregnancies. Have I had issues with previous pregnancies? You know here, because I've explained this to you, that obviously I've had some kind of issues because I've already had surgery once to remove uterine thyroid. So we need to kind of know my history with my pregnancies. Did I have any issues, complications? We need to know my last known period. What else do you think is important to know in pregnancy? In general, we ask this question really of everybody, but we specifically ask in pregnancy and actually draw blood to confirm this. Let me give you a hint. You had to supply this information when you started nursing school. You had to prove to us you had had these. Vaccines. So you're going to know my immunization status. They are going to draw blood to test for rubella to see if I'm still immune to rubella. Pregnant women cannot have live vaccines, and there are certain diseases, rubella being one of them, that if a pregnant woman contracts, it crosses the placental barrier and it can cause birth defects and or fetal demise. But if we're pregnant, we can't give them the MMR vaccine because it's live. So, immunization status, I'm going to tell you, so right there, Gravida, that tells you the number of pregnancies that I've ever had, and that includes my current pregnancy. So you always count with Gravida the current pregnancy, so previous and current, no matter miscarriage or not. Para are the number of pregnancies that made it past 20 weeks, regardless of outcome. So even after 20 weeks, if the baby did not survive, that still counts in para. If you miscarried at 17 weeks, it doesn't count in para. Does that make sense?
What was Gravida?
Gravida is your number of pregnancies, including your current, no matter what, including the current one.
What was the number of weeks for para?
Huh? Para is your number of pregnancies past 20 weeks, no matter the outcome. So it doesn't matter if baby survived all the way to the end. If you got past 20 weeks, that goes into para. So I have 2 living children, so there's my para. If I had 1 living children, but I told you that my other pregnancy I miscarried at 21 weeks, what would that number be? 2. It would still be 2. If I said I had 1 living children and I had a miscarriage at 12 weeks, what would that number be? 1. Okay. Both of them are boys that live at home. So my history, my first pregnancy, I was on bed rest at 24 weeks due to early dilation, complicated by uterine fibroids. Baby was born at 36 weeks and spent 2 weeks in NICU. My second pregnancy, I had gestational diabetes. Baby was born via C-section at 39 weeks, no NICU stay. Is there anything else y'all think? We're going to get to the menstrual period. I know that part. Anything else y'all think we need to know? Or do y'all think you have a pretty good picture of where I stand right now? Y'all are the nurses. Y'all think y'all need to know anything else at this point before we move on? So yes, usually when you go, just like you do at other doctor's office, they'll ask familiar history. In an OBGYN office, they tend to ask a little bit more about father's history and those types of things. I'm not really going to ask you that on the test for this. We're just really looking like what are we focusing in on mama, because really that's going to be quite clearly they give you a sheet of paper to ask you about dad's medical history, immediate grandparents, your sibling, his sibling, yes.
Gestational diabetes, like was she?
So you could ask, it was diet control. I did not take anything.
C-section wasn't emergent.
Nope. Planned.
I mean, would you ask that?
So when you go in a patient's room, hey, Miss So-and-so, I'm your nurse for today. How have you been feeling? So you're gonna know what symptoms I've been having. How have you been feeling? What? So, I'm gonna tell you I've missed my period. I have vomited every morning for a week. And every day by 3 o'clock I'm taking a nap because I just can't stay awake. I know y'all had a test yesterday. I know you didn't have one. I would not have looked at this either. So we're gonna go through this, but I do kind of want y'all to think. So these are signs of pregnancy, but are they considered presumptive, probable, or positive? Presumptive. So presumptive is what mama is feeling. I'll also tell you I took an at-home pregnancy test. Presumptive, probable, or positive? It's probable. So probable is like, this is what mom is feeling. Could I miss my period for some other reason besides pregnancy?
Yeah.
Could I be vomiting every morning because of something other than pregnancy? I could take a nap every day at 3 o'clock right now in my life, and I have no functioning parts, so there is no way that I am pregnant. So all of those have another reason. Can you have a positive at-home pregnancy test and not be pregnant? Yes, you can. It can be a false positive. So if there can be another explanation, it's going to be presumptive or probable. Your other probable signs are really going to be things that your physician would see. You're not going to necessarily see them at home. And it is certain ways that your cervix changes in color, kind of in size and shape, things like that. You can't see your cervix at home. It's going to be what your doctor sees, but there's also other reasons that might happen. So the biggest thing is just know a positive home pregnancy test is probable. So what do you think we're going to do at this first visit? We've gone through my medical history, we've gone through my pregnancy history, you've asked me how I've been feeling. What are we gonna do now? What do we have to do? Well, we'll get a urinalysis in lab, yes, we'll go there. But you have my presumptive signs, you have my probable signs. What do we have to do? We have to do an ultrasound. We have to confirm I'm pregnant. Right now, we don't. There could be other explanations for all that. You have to confirm I'm pregnant.
Yeah, that's what the blood work and the urinalysis.
Okay, well, the urinalysis is an at-home pregnancy test. Blood work, could it also be elevated for other reasons? When you look at my HCG, when you look at all of that, could it be for other reasons?
What would the HCG be elevated for?
You can actually have, like a molar pregnancy, there is no baby at all, and it elevates that HCG. So there are other reasons why it can be. So what would be your positive signs of pregnancy? It's going to be an ultrasound of fetal heart tones. Fetal heart tones. So you hear the fetal heartbeat. So here we go. Y'all take me to ultrasound. We see little baby. We got heartbeat down here. Does everybody have like phone, computer, something? I want y'all to Google estimated due date calculator, something like that. Y'all can share with a friend something, but y'all gotta figure out, y'all gotta tell me when I'm due and how far along I am. No. So my last menstrual period was July 2nd of 2025. So pull up your estimated due date calculator, and y'all tell me when my estimated due date is and how far along I am.
Yeah.
Oh, there should be an easy calculator. Doesn't ask that. You literally just put in last menstrual period.
April 8th.
April 8th is when I'm due. I'm 10 weeks pregnant. put this in, they're gonna establish your due date. Unless, even if your ultrasound measures ahead or behind, it's got to be within a certain range, and the doctor has to be feel really confident before they're going to change this. Okay? What? Okay. So, just a funny story. Last night I was just trying to kind of get like this ultrasound is right about 10 weeks. So I was trying to do some math last night and figure it out. April 8th is my husband's birthday. I thought that was pretty funny when I did the math. I did it all came out that way. All right, so what trimester am I in? First. So, what is first trimester? Week what to week what?
1 to 13.
Not 1 to 20.
1 to
How many
13.
trimesters do we have in pregnancy?
3.
3. And how many weeks are you typically pregnant?
40.
40. So if 1 to 20 was the first trimester, we would struggle a little bit to get 3 trimesters in.
Complain about the doctor like it never ends. The 5th trimester.
It doesn't. All right, so we're in first trimester. Y'all told me we're week 1 to 12.
So 1 to 12 is
Your first trimester.
second. 13 to 28.
13 to 28. We're getting there. Let's not skip ahead. You're good. You got it. All right. So the other thing we're going to do on my first visit is we're going to get a bunch of blood work. So we're going to do a CBC. Why are we going to do a CBC? Yep. What goes up, or what should go up during pregnancy?
HC volume.
Yes. Blood volume. Who said blood volume? Thank you. Thank you. Blood volume. Why? Yes. There's another thing there. So we have to, we're now supplying blood for 2. So what's something else that women in general, even outside of pregnancy, can have issues with that we would notice on a CBC? Because we have periods, and so we bleed once a month. Anemia. So we want to make sure mom's not anemic. What are we going to tell mom she has to take every day?
Folic acid.
A prenatal vitamin. If we are anemic, we're going to tell them to take it with iron. If we have any kind of iron supplement, what are we going to tell them that they need to take it with? Iron can cause GI upset. So what are we going to tell this mama who's already vomiting every morning? Take it? Yes. And if we're vomiting every morning, then we might want to take our prenatal vitamin at night. Okay? What else needs to be in a prenatal vitamin? Folic acid. Does anybody know why?
Brain.
The spinal defect. Yep. All right. We're also going to screen mom, no matter what she says her history is, for any STIs. And then we're going to type and screen. Why are we type and screening mama?
For H factor.
Yes. So one, we need to know that blood type, and we need to know positive or negative. Who else would we need to know?
Dad.
Dad. So if they know dad, because if both mom and dad are negative, are we going to be super worried? No. If mom and dad are both positive, are we going to be super worried?
No.
If mom is negative and dad is positive, is that when we worry?
Yes.
Yes, and we'll talk about that. All right, so what are some things? Now remember, my last C-section was in 2014. It's been a hot minute since I've had a baby. What do y'all need to tell me about having a safe pregnancy? What are some things that I need to know?
No smoking or alcohol.
Don't eat sushi. Nothing raw. You can if it's cooked. Nothing raw. Don't drink alcohol. No hot tub.
No medications you can't take.
No smoking.
You can't cruise after 24.
What are you saying back there?
Cat litter.
Yeah, yes, if at all possible, have somebody else scoop the cat litter. If you absolutely have nobody else, wear gloves, wash it, something, go find a neighbor, go with somebody.
Warm your belly meat.
They tell you to warm your belly beans. Cats can transmit toxoplasmosis to you, mom, and it would be dangerous for mom and fetus. What else?
You can only take certain over-the-counter meds.
Yes, safe, you wanna do a safe medication list, so no NSAIDs, so no ibuprofen, Aleve, none of that. Mom has a headache, Tylenol. Sorry, that's all you get. Stuff like Chuck, you get some Tylenol. They, unless the vomiting is severe, they try not to even give you Zofran. But if it's severe and you really need it, Zofran is what you will get. They're going to try other stuff first. So, what are some things you could tell me, because I'm vomiting every morning, what are some things you can tell me to help with that? Outside of meds. Don't go to the med route. Peppermint, lemonade. Okay, what else?
Ginger ale.
What could you tell her to do before she ever gets out of bed in the morning?
Eat.
Eat what? What would be something good to keep her? A saltine cracker, something high carb.
Butter cracker.
Yes. So tell her to keep a little stash on her nightstand before she ever gets out of bed. Are you going to tell me to eat 3 large meals or several small meals?
Several small.
Several small meals. Yes. Is it better for me to go to the cafeteria at the hospital and get meat and veggies, or to go to the grill and get the chicken fingers and fries? Okay, I'm going to want the chicken fingers and fries, but it's better for nausea. Avoid greasy food. That does not help with nausea. Now I will say some salt help, but I'm just telling you what the literature says. I'm not. Would I go pick the meat and vegetables? No. I'm going to go pick the French fries. I'm telling you what literature says. So ignore. Any of you who've been pregnant, ignore what helped your pregnancy. Go with what literature says, because that's what I test you on. Do we want to tell mom, if you're feeling nauseated, just don't eat? No, because what does mom need? She needs nutrients. She needs extra calories. If she's not eating, who else is not eating? Baby, and baby's not growing. Okay? If it's really nausea, if the nausea is really bad, you can tell her to give it a little bit and push back a meal. Maybe just eat those crackers, see if it subsides, and then eat a meal, but we still want her to get her calories in the day, if at all possible. So if you have somebody that is always nauseous and throws up in the morning, then you can just tell them to eat more at every meal after that to kind of get, if they can't do breakfast. So then kind of have more like a brunch, and then lunch, and then dinner, that kind of thing. And then, of course, if they're vomiting, we want to make sure they're hydrated. What is it's really like a spice or supplement or something like that that is known to help nausea. Ginger. So ginger ale. Man, I'm sure they have them other places at Target, but I found them at Target. They're these yummy little, it's almost like a cough drop, but it's ginger and, oh, it was the best little candy.
Oh, the
roll,
Preggy
and I
Pops?
love it. And they have, pregnancy pops. And almost all of that stuff has ginger. This would have made me vomit more than help, but in your literature it talks about aromatherapy. I would have, your smell is heightened in pregnancy. I'm not sure any pregnant person, but it's in there. And then it says go outside and get a breath of fresh air. We live in Alabama, and as you can see, my last menstrual period was in July. I am not going outside in the summer to get a breath of fresh air. All right, so what else? So think I told y'all last semester that I go to the gym.
Oh, yeah, that's fine.
What, can I still go to the gym?
Yes.
Yes.
Lift weights.
The rule of thumb with exercise, if you were doing it before pregnancy, you can continue it while you're pregnant. You will eventually have to modify. So we're not gonna lay flat on the floor if you're doing something that you're gonna have to be elevated. We're gonna get to a point where we're not gonna do crunches. We're not gonna do things like that. You might have to lessen weight as you get further along in pregnancy. But, like I said, if you were doing it before you were pregnant, you can continue while you're pregnant. If I have been sitting on my couch every afternoon for the last 3 months, and I am now pregnant, and I say, hey, Burn Boot Camp is having a special, and now that I'm pregnant, I want to make sure I'm healthy, what are you going to tell me? No. You're going to tell me if you would like to do something, you may start a walking program. But we are not going to go start a strenuous, in the gym weight exercise if I haven't been doing that, okay? What are you going to do if she asks, as her belly grows, her seatbelt's uncomfortable? Too bad, so sad. What do you do? Below your belly and across your hips to your pelvic bone. My husband likes to, he really doesn't, I'm just using this as an example, but I tell you, my husband likes to smoke marijuana in the evening to relax, and I usually sit with him while he does that. No. He does not. He does not use drugs at all, I promise. If he did, he'd be out the door. I'm a mean one. He'll tell you otherwise, but I say I'm mean. What about a bathtub? Can I take a bath? Yeah. Can't be as hot as you want it to be. Is the better option a shower?
Yes.
Let's see what else. We've already talked about immunizations.
So I have a question about
Yes.
the bathtub. Because like bathtubs can cause like yeast infections and stuff like that.
They can.
So why does it stay from pregnant?
So, again, your better option is a shower, but sometimes especially like if they, later on, if they start having like sciatic pain, like baby sits, sometimes just sitting in a little bit of warm water kind of helps. So it's not that we don't ever do it, but you would not want to do it every day. The other things, as they get further in pregnancy, like once the mucus plug comes out, and we'll talk about that later, or definitely if for some reason, really if your water broke, you'd be in the hospital. Anyway. But if there was anything that all of a sudden we have an opening to baby that we shouldn't, then baths are out. Okay? What about sex?
Yes. Okay.
Yes.
Unless
Unless your doctor says, so my first pregnancy I went on bed rest at 24 weeks because I was dilated. That was a no-no. It's okay, he was on the other side of the world. I know, we're done. I didn't have to tell you. So they can, but most of the time, they're only going to do it, a lot of times they're going to do a cerclage, which is, if you start dialing, you're going to do it in your first trimester. I was too far along, and they were afraid that it would induce labor. So, I went on bed rest, and stayed on bed rest for 12 weeks. He gets 36. All right. So now it's been a few weeks. I've gone home. I'm coming back for my next visit. Med, I'm in my second trimester. Where am I?
13 to 27 weeks.
Very good.
So,
All right.
Is it 7 or 8?
I think it's 28 technically. Where's my thing? 222. I think it's either 27 or 30. Anyway, it doesn't matter. That part doesn't matter so much. But we're in the middle of pregnancy.
We got a YouTube video.
27 and then 28 first 30. Anyway. All right. So I kind of forgot to tell you. Typically somewhere 8-10 weeks is when you really can hear the heartbeat the first time. It can be as early as 6 weeks. Most of the time it's closer to that 8-week mark. That first ultrasound is a vaginal ultrasound because you're not going to really be able to see baby or hear heartbeat from the external ultrasound. So now we get to second trimester. So we're going to start having doctors going to come in and we're going to do fetal heart rates at every visit. They're going to do the little Doppler. It's not going to be a big ultrasound every time you come. So doctor comes in, little Doppler, and we go from there. We're going to do fundal height checks. So mom comes in as belly is growing, and they just, I see Meg back there, what's that? I'm just playing. So they have a measuring tape, just like you use for sewing or something else. She literally comes in, she finds the top of your fundus, and then she stretches the measuring tape to the top of your pubic bone, top of your uterus.
Oh.
Sorry, I guess I should explain that, but I kind of was thinking like anatomy cath, y'all should know.
Haven't heard that word.
Okay, your fundus,
It was fun.
your fundus is the top of your uterus.
Okay.
Okay. Sorry. I shouldn't have assumed anatomy and physiology was sticking in nursing grade. So she's going to find the top of your fundus. That's where the top of the measuring tape goes. She measures down to the top of your pubic bone. That measurement in centimeters should correlate to the number of weeks pregnant you are. So if my belly measures 15 centimeters, then I should roughly be what? 15 weeks pregnant.
And it is too much.
So just a,
It's measuring like 20 and you're 15.
so okay, let me tell you. So again, going back to, by the way, now my birth date and my age were a lot there, but all of that mystery was mine. So with my first one, I found out that I had fibroids after I was pregnant. I didn't even know I had them. I'd had them for a while. They said the famous last words, they don't really ever cause problems in pregnancy. Should have never said that to me, because I'm going to defy the odds. Ask my mom. I've always been this weird medical child who defies all the odds, and I don't do anything normal when it comes to medicine. So mine grew exponentially with pregnancy. And I measured like I had twins. So my 3 fibroids that I had, if you put them together, measured the same as another fetus. So do you think that fundal height checks were really accurate for me? No. I had so many ultrasounds, which was great because I got to see baby all the time, because that's the only way they would know if baby was growing. Because that's the other indication. If my belly is growing, then we know baby is growing. Okay? Typically, you'll have one ultrasound in your first trimester. You have your big one, which we're going to watch in just a second, in your second trimester, around 18 to 22 weeks. You may or may not have another one before birth, but a lot of people get 2, 3 at the most. I had one every 2 weeks. So for me, yes, fundal height checks didn't work. I measured like I was carrying twins.
Where's the picture?
I'm going to get there in a second. You're also going to do, Lauren already talked about this, you're going to pee in a cup every time you go. And they're going to check for glucose and protein in your urine. What are we worried about if every time I go I'm spilling lots of glucose?
Gestational diabetes.
Gestational diabetes. And protein is along the same way, but what's the other reason we're worried if a mom is spilling a bunch of protein?
Preeclampsia.
Preeclampsia. Again, you'll learn about that next semester. I'm not going into that. Just know that's why we're checking your urine every visit. Before we watch our really sweet video, what are some other expected assessment findings that you would expect during the second trimester? Huh? Y'all gotta talk louder.
What was your question?
What are other expected assessment findings of a mom in her second trimester? So,
Assessment.
is my nausea better or worse? Typically, we're gonna go with a typical pregnancy. Should be better. Is my fatigue better or worse in the second trimester?
Better.
Typically better. This is usually the best trimester pregnant women have.
Yeah, should be better.
What are some things that would get worse? So my belly has grown and everything is being displaced in my abdomen. So what might I start having when I eat?
Heartburn.
Heartburn, back pain.
Towards the end of the second.
What else? We talked about how I could have issues with constipation. So if I'm having to bear down all the time because I'm constipated, what might I have now too? Hemorrhoids. I know. Doesn't it? I mean, this makes everybody want to get pregnant this lecture. So the other thing you can have as things stretch, you can have stretch marks, but that's just part of it. So you can have what we call round ligament pain, and it can be like, oh my word, take your breath away. I called because I was like, have I gone into labor? It was with my first pregnancy because I didn't know. Because again, remember, I grew exponentially with my first one. And it can be, so when moms call, they're talking about, it can be some rough pain because those ligaments you have stretched as you're growing. So they can have that. What else? If you're used to sleeping in one position and now you start having this big belly, what's going to happen to your sleep at night?
On your side.
If you're on your side, they can't sleep on their back because we will compress.
All these pillows.
Yes, so you can be hot. You can be uncomfortable because you can't get in certain positions. So we're going to have some insomnia.
You might be peeing a lot.
You're going to be peeing more or squishing a bladder. You also, even before you start growing, some women will report they have urinary frequency in first trimester. Does anybody want to guess maybe why? What did we say increased with pregnancy? Volume. Okay. Let's see if my little link works. So now, here we are. I'm going to have my anatomy scan. Come on, work. Now, ladies, features on you straight from my video like you did last night when I was doing this. Oh. Hold on. I was so excited about this. It worked so well last night. Technology, I hate you. baby's hand right there is on his face. There's a reason why I picked this video, and you'll see in a minute. So when he shakes and it gets blurry, they're trying to make baby move and move his hand. The video told me he was a boy, but we don't actually see that. So you see belly, there's some legs down there. Our other arm is kind of over here. So you're about to, we're gonna swap, and here's 4D. So see baby's hand over his face? And there's a leg, and there's another one over there. More kind of, I think that's an arm kind of all curled up. There's an ear, arm and elbow. See? So we're gonna go back, we're gonna shake baby no more. Get him to move his hand. So during this ultrasound, they're going to measure, the length of the femur bone. See, there's face. Look at Josh. So anyway, they're going to measure the belly. They're going to measure our head circumference. They're going to measure the length of the femur. They're going to take a bazillion different measurements of baby to get a really as accurate as they can on ultrasound. How big we are, estimate kind of weight, are we matching up with our gestational age, all those types of things. They will flip it when you get an ultrasound, and they actually will look at the blood flow through the heart, so it'll be red and blue so they can see oxygenated, deoxygenated. They look real closely at the brain, and they see the structures that they need to see on ultrasounds. So they can tell a lot from your anatomy scan, and that's what they call it, it's a big anatomy scan. So there's my 20-week ultrasound. Y'all were sweet and gave me pictures to take home. I didn't want to go from the beginning, sorry. Alright, so I'm going home, I'm happy, I'm at 20 weeks, I'm going to come back in 4 weeks, so at the first part of pregnancy, you come about once a month, so about every 4 weeks, okay? So, this was about 20 weeks, I'm going to come back at 24 weeks, we're just going to listen to heart tones, I'm going to pee in a cup, you're going to measure my belly, then in 4 more weeks, I'm coming back at 28 weeks, so now I'm in what?
Third trimester.
Third trimester. So, what are some things we're going to be doing during my visit in the third trimester? We will have a glucose tolerance test. So this is where we test for gestational diabetes. I will have to come in. They will ask me to be fasting. I've done it 2 different ways. I have been sent home with this nasty sugary crap drink, and I had to drink it on the way to my OB office. And then I've gotten there and they made me drink it, and I sat in the waiting room. But anyway, you drink this awful drink that is super sugary. You sit there they draw your blood before you drink, then or maybe you just, I can't remember. Anyway, it's been long. They draw your blood after so long of you sitting there after an hour. If your glucose is above a certain range, then they say you failed your test. You have to come back for a 3-hour test. And the 3-hour test is what confirms whether or not you have gestational diabetes. So if you are unfortunate enough to fail your 1-hour test, you get to drink that nasty drink again. And instead of sitting in the office for 1 hour, you sit there for 3. Then they take your blood at 3 different intervals. It stinks. A lot of the rest of your visit is going to be the same thing we've been doing in the second trimester. Fetal heart tones, peeing in a cup, looking for glucose and protein, measuring our fundal height, all those kinds of things. What else? By now, mom is able to feel baby move. So if it's a first-time mom, usually it's going to be somewhere around that 18 to 22 weeks when mom really recognizes that she's feeling baby. baby is moving and mom probably feels baby before then, but doesn't, first time moms a lot of times don't realize that that's what they have felt. Second, third time moms, since they've gone through it and they kind of know what that sensation is, sometimes they'll start reporting earlier in that second trimester that they feel baby move. When we get to third trimester though, we really are asking moms consistently, how is fetal movement, okay? Because we want to know, is baby moving? And we give them kind of parameters. You know, if you don't feel like baby is moving, because babies go through sleep-wake cycles, so you're going to have periods throughout the day that it's normal that not to feel baby. Baby's asleep. So, and they get in patterns just like we do. So we kind of tell mom, hey, if you haven't felt baby as much as you typically feel baby, like there's not really a set, you have to feel baby this much, because everybody's a little bit different. And a lot of times we'll tell mom, drink a little caffeine, eat a little sugar, kind of sit down. And sometimes we'll tell mom to lay on the left side so we get more blood going down there. Those are kind of things we tell mom to do when we say, okay, if you haven't felt baby move after X amount of time, call back. So we really check with moms about baby movement. Does anybody know about when we will check for Group B strep?
36 weeks.
35 to 36 weeks. Okay. Group B strep lives in the vaginal area. It can be a kind of a normal flora type thing, okay? So, and sometimes it, like when they test for it, sometimes it's there, some like, it's not harmful for mama. Let me say it that way. It is not harmful for mama. The reason we test for it is because as baby comes through the canal, it can cause issues for baby. So if a mom tests positive for Group B strep, we don't do anything at that visit. That goes in our chart, so when mom comes in labor, we hang antibiotics, and our hope is to get antibiotics in like 2 hours before delivery. Okay? So it literally, we test it not because it's harmful to mom at that moment, but because it's going to dictate treatment when mom comes in for labor. So I told you I come in every 4 weeks. Then towards the beginning of my third trimester, I start coming in every 2 weeks. And then at what week do you think they're going to start making me come every single week?
36 weeks.
35 to 36. Monitoring, yeah. You're gonna get vital signs at every visit. You're gonna let mom know that if she starts having contractions that are not relieved by walking or not relieved, sometimes they can walk and relieve them, sometimes they can sit down and rest and relieve them. If they go away, they're not true contractions. They're Braxton Hicks, they're practice. Your body's trying to get ready. But we tell parents, mom, if you have had contractions that are like 5 to 7 minutes apart consistently for an hour or more, then you need to call. Because that's when we start thinking you're going into labor. They're going to come in. A lot of hospitals now have what they call OBEDs, and that's usually where your office will send you. They will hook you up to monitors, they will check, they will do all of that and kind of determine, do we think we're in labor or not. We also want to tell moms, we want to kind of talk to them about what they may or may not feel as far as their water breaking. It can be a trickle or it can be a gush. So if mom is unsure, she thinks her water might have broken, call the office. So lots of third trimester is basically kind of educating on mom, when to call, what to expect, those types of things. Third trimester is also where if mom will get her first RhoGAM shot, if we have compatibility, so if one parent's positive, one is negative, then mom's going to get a RhoGAM shot. So if one parent's positive and one is negative, we don't know where baby will end up. If mom is positive and baby is negative, and with first-time pregnancies, it's not as big of an issue. But once that blood mixes during that first pregnancy, then if baby is negative and mom is positive, or vice versa, mom's gonna develop antibodies. So in subsequent pregnancies, then our body is gonna do what our body is supposed to do. It's going to activate and it's going to attack baby because it's developed antibodies, it recognizes it as foreign. So that's where RhoGAM and all that comes into play. They will also get a second RhoGAM shot after delivery. Any questions about being a antepartum, working in an OB office nurse? Okay, y'all go take a break. And then when we come back, we're gonna go into labor. I also I really like to see what Ethan would put his name up as. Like that was entertaining for me last time. So. I know, and I need to see it again. Don't do that. That would just use my little brain. Alright, is everybody back? Oh, by the way, all we're doing today is antepartum. Let's make sure you understand your words. Antepartum while I'm pregnant in the OB office. Intrapartum, I'm coming in for delivery. Postpartum, after delivery. Ante, intra, post. Okay? She didn't want to experience the pregnant.
Whoa.
Just saw your mouth.
I agree while y'all were wrong. While y'all went to the bathroom.
What is under there?
My baby, what do you mean what's under there?
Wait, what's
It is, I'm
Renesmee.
sorry, yes,
Renesmee.
it is my vampire baby. So it sounds like some sneak out. Oh, I need to ask y'all, because I told y'all had homework over the break. I bet none of y'all did it. I didn't go walk back to the future. I told y'all, figure out who my J-Box was. You did, Austin? Yes! Okay, if I can find a way to get you some bonus points, I will. Wait, I'm kidding. I can't really give you bonus points, I'm kidding. Okay, Lauren, you probably did already.
We should take away points for not knowing all that.
I know, but y'all have no idea how old you made me feel last semester when you were like, who's Michael J. Fox and what is Back to the Future? I was like,
She did that.
oh no! My kids would even sing Back to the Future. Alright, so I called the office and I told you that my contractions were every 5 minutes apart. They've been that way for about 90 minutes. You told me to go to labor and delivery at Grandview. I don't care. That's not where I deliver my babies. I'm just picking hospital. So now y'all kind of got tired of working in the OB office, so you decided to go into the hospital where you only have to work 312s and make a little bit more money. So y'all have been y'all have transitioned to L&D nurses. Okay? So look at y'all. Y'all are like at it. Y'all were so smart you skipped 2 semesters of nursing school and went straight into nursing to all work in the same department. So here we go. So I'm coming in, y'all, it's decided we're gonna admit me, I'm in labor. So we're always gonna get vital signs. That's like every patient across the board, whether they're pregnant or not. You're going to ask me my health history. Okay, so in a perfect world, would everything from the OB's office magically appear in L&D?
Yes.
Yes.
In a perfect world.
Does it? No. So guess what? All that stuff that you asked me during antepartum, as the L&D nurse, you're going to ask me again. Okay? So you're going to ask me my age, my date of birth. You're going to ask me me my allergies, you're gonna ask me past medical history, surgeries, previous OB, obstetric history, all of that kind of stuff. The other thing you're gonna wanna know, do I have a birth plan? So these are more popular now than they have ever been. It used to be women went to the hospital, whatever the doctor said to do, that's what you did, you had a baby. So as we learn and we grow and evidence comes out, we now give moms a little bit more choice of how they want their labor to go, okay? Does mom want to be medicated? Does she want to go unmedicated? Does she want to have a water birth? Just so you know, the baby is not actually born in the water. They come out before then, they just labor in the water. What else? Moms can have home births now. I think it's really cool, but I would not ever be able to do that. Like, I have friends that have done it, I know people have done it, and I'm like, man, that looks just like lovely and perfect, and I would be a ball because I know too much. So anyway, all sorts of things, and guess what? We have to follow it. We cannot make that mom do something that mom does not want to do. Now, there are extenuating circumstances. I'm not going all the way down those rabbit trails. You know, as far as if mom was choosing something that would be harmful to her and baby, there are some ways that things can be overridden, but we're not going down that. So most times, if mom comes in and says, I don't want this, I want this, and it is in the realm of possibility, then we kind of have to honor those wishes, okay? Some moms come in and they are basically like, absolutely no way do I want a C-section. Like, I will do everything possible to avoid that. We're going to try to get to that goal, okay? You're gonna immediately get me in a bed. So, okay, the one on top is baby. And we're gonna move it around and find baby's heartbeat. The one on the bottom, what do y'all think that's monitoring? Contractions. Okay, so you got my history, you've hooked me up to a monitor, we've got fetal heart rate. You're gonna ask me, has my water broke? Okay? If it has, we're gonna wanna know about what time, how much, and what color. What color do we want it to be? Clear. We want it to be clear, so like a good pea color, like it might have a little bit of yellow tinge, something like that, but for the most part we want it to be clear. It might have a little pink tinge to it, that's fine. We don't want it to be like solid bright red, like you're hemorrhaging, and because that's a big no-no. We also don't want it to be a green-brown color. If it is a green-brown color, what has happened? It's meconium. Baby has pooped in utero. And baby poops in utero because it gets distressed. Baby drinks amniotic fluid. If there is poop and amniotic fluid, what has the baby now done? It has aspirated meconium. Okay? So, that's why we need to know color. Amount kind of gives us an idea. Have the membranes completely ruptured, or is she partially ruptured? If we're partially ruptured, the doctor may have to go finish breaking the water. Or maybe he has to move mom around. It does it on its own. Why do you think we need to know what time?
24 hours. Right?
Infection. So with prolonged rupture of membranes, the longer they're ruptured, the higher the risk of infection. We really want baby to be born within 24 hours of membranes rupturing in a perfect scenario. Okay? Do moms go longer with ruptured membranes? Yes. We get antibiotics on board. What's another reason we might be worried about time? What are your membranes? What is that? Say it again.
Baby's getting dry.
The baby, yes. So the baby floats in that fluid, it cushions baby, all of that kind of stuff. As we lose fluid, we might not be, your body produces it, baby pees it out, drinks it, pees it out, drinks it, all that fun stuff. But we need it. So if you rupture too early in pregnancy and we're prolonged, then we've got to keep an eye on your fluid level. So you already have, I came in and I told you I was having contractions every 5 minutes, it had been going on for 90 minutes. So now you have me on a monitor to really see how frequent my contractions are going. What else can you see if I'm on a monitor with contractions? How intense they are. And we'll look at a strip in just a second. And the last thing you're going to do is you're going to see how much my cervix is dilated and effaced. So dilation is how much the cervix has opened. So you can see we start up here with 1 and we go all the way to 10. Does your cervix open like a perfect circle? No. This is just a representation, okay? There shouldn't be a huge discrepancy between nurse and physician when you get checked. There should be a huge discrepancy between nurse and nurse. Can there be, like, I go in and say that somebody is 3 centimeters and another nurse says 4? Yes. Is that a big, huge deal? No. If one nurse said I was 10 and another nurse said I was 8, that might be a bigger deal, because at 10 we're going to push. We want to really make sure we're at 10. We don't want to push before that, okay? So, anyway, so you're going to check dilation. Anybody know what effacement is?
Thinning.
How thin? So your cervix opens and thins, okay? So both have to happen before we can push and deliver babies. So dilation is in centimeters, effacement is in percentage.
So it's how thin?
So it's how thin your cervix is. So your cervix thickens up. Because remember, we're going to make sure that baby is completely sealed off during pregnancy. So your cervix is closed, it thickens up, you have a mucus plug. We're making sure as much as possible nothing can get up in there to baby.
So it thins as you get closer to delivery?
Yes. It does that and dilation kind of happen at the same time.
You said dilation was the centimeters, effacement and what?
Percentage. So when you get to 100%, that means you're completely thinned out, you're completely effaced. All right, so not only when a nurse checks you, are they feeling for how much you are dilated and effaced, they are feeling for baby. So ideally, what part of baby do they want to feel when they check you? The head. So your station is where baby's is in mom's pelvis. So your markers are your ischial spines, okay? And that is 0. That is station 0. Sorry. Your ischial spines in your pelvis, if the baby's head is even with mom's ischial spines, that's station 0. ISCHIA. If baby is higher than the ischial spines, take this off, this hurts. Then we are negative. So -1, -2, -3, -4. The higher the negative number, the further up baby is. I'll go back to these other sides. So, the lower baby is, so the more we're ready for delivery, we go into the positives.
So the lowers?
So the lower the baby, positive. So think about this. We want baby, if baby is in the positive as a station, baby is getting ready to go. If baby's in the negative, baby is saying no. Positive go, negative no. So you'll go to about +3, and that, then we know baby is fully engaged and ready to start coming in. Now, baby does not necessarily have to be at this +3 to start pushing. To start pushing, we've got to be 10 centimeters dilated and fully effaced. Part of what we're doing when we push is getting baby to continue this downward descent, okay? But if baby is too far up in the pelvis, we're gonna be laboring a lot longer and it takes more to get baby down. We really, when we start pushing, we kinda want baby at least at that 0, or a little bit lower so that they're really engaged and we're not gonna have to have mom push us on.
So the station though doesn't tell you when to start pushing?
No.
Or like how long you're gonna push?
Yes. So the other thing that we're checking is fetal presentation or fetal lie. So how is not only where, okay, fetal presentation. What part is presenting first?
The head should.
Well, the head should, but that's what fetal, the definition of fetal presentation. We're feeling for what do we feel first? Ideally, we want to feel the head.
Ideally, we know where you're.
Ideally, yes. But can babies flip at the last minute? Yes, they can. They can flip.
Mr. Zachariah.
So, just because at 38 weeks you went to the OB office, she checked you, and she felt baby's head does not mean when you go into labor at 40 weeks that baby hasn't flipped, and now when we check, we feel butt. Okay? Breech can be butt or breech can be foot. You can be a footling breech. You can deliver a baby breech. Do they typically do it? No. A lot of times if it's a footling breech, they'll go have a C-section. So the doctor you have to have a physician that's pretty confident, just because it puts, it's a much harder labor for mom. There's risk for mom, there's risk for baby. We want baby head down. Transverse and oblique, you can kind of get them to move, and sometimes physicians will do, they're called Leopold's maneuvers, and they literally do these things to move baby around. One thing with oblique that you worry about if baby doesn't flip to this position is sometimes you'll have the shoulder that wants to come out first. Or you'll have a shoulder and like head trying to come at the same time, and they can have shoulder dystocia. So basically baby's shoulder gets out of socket and dislocate. So again, head down is what we want. Yes.
When the baby's flipped like this, can we visually see it on the stomach?
Sometimes, so you can kind of, like, if you go to an appointment and you kind of figure out, or like I could, once I'd been to an appointment, I could kind of feel and be like, okay, this feels like butt, this feels like head, and it feels a little bit different. I wouldn't say that for everybody. I don't know though if any of mine had flipped, if I really would have known. You know what I'm saying? Like, so I think a doctor could feel and know. I don't know that you as a mama would always be right in feeling and know. The only thing I definitely could figure out were feet. When they kick, they kick. And sometimes they would kick, and I never had the really cool, like you could see the foot indentation on the outside. You know, some people can do that. The baby will kick and put so much pressure. You can literally see the outline of their foot. I never had that, but I definitely could be like, okay, that's a foot and we're kicking. Do you want to hear a fun, cool, like, story, or I think it's cool? Sorry, I told you I had fibroids. So I went in one time and they'd asked me about how baby was moving, and I was like, well, I really haven't been feeling him as much as I usually do. And so, again, I get ultrasounds all the time anyway, so they're like, well, okay, well, let's go take a look at it. So they put him up on a big screen. For those of you who've not had babies, you literally go in a room, there's a big TV or screen or something, it's dark, you're sitting in a chair, and you just kind of get to watch baby on the screen. It's really sweet and cool. Went in, and they brought him up, and he was going to town. His little legs were doing this, and they're like, you can't feel that. It's like, I can't feel a thing. Like, I'm physically watching him on a screen do his legs like this inside of me, and I'm feeling nothing. He's kicking a fibroid like it's a soccer ball. And I can feel nothing. But it was so cool to watch those little legs just going, and I couldn't feel a thing. So, my first pregnancy, like the only part today on my Facebook memories, it came up, I was having to be positive. My husband was overseas, he wasn't even here. He was deployed. So, I was having to find lots of positives during that time in my life. So on my Facebook memories today, it popped up that my positive for the day was being on bed rest. Who wouldn't want to be on bed rest on a Monday? Because nobody wants to go to work and everybody wants to lay in bed, and I got to do that. So, because 13 years ago, it was apparently a Monday. So, anyway, lots of fun with my first pregnancy. Although I will get to say I got to sleep every time I felt so tired. So that was about the only, that for my first, that was great. Luckily, I was not on bed rest for the other two. That wouldn't have happened. So anyway, presentation means what presenting part. So when we feel what part of baby is trying to come out first. What part of baby do we want to come out first? Head. Okay? Any questions about station and presentation? All right, so we're going to say that baby is head down. Let me go back a few slides. We talked about that. You can kind of see no effacement at all. And again, see your cervix does not open up like a circle. And here we are where we're effaced. Okay? Here's your mucus plug. This is your vaginal canal. This is your cervix, and you can see how it opens up. I think before that's just okay. Pelvic anatomy. So here's your pelvis. Is this anterior or posterior? Anterior. So that makes this posterior. When we are talking about baby's head and orientation in the pelvis, it is in relation to the occiput, so the back of baby's head, and where that is in relation to mom's pelvis. So, if baby is like this, pelvis doesn't stay. If baby is like this, what part of mom's anatomy is the baby's occiput on? Anterior pelvis. So it's occiput anterior. This is the ideal presentation for baby. We want back of baby's head to front of mama's pelvis. If we are this way, we are occiput posterior. Baby can still deliver this way. If you're ever in labor and delivery, which obviously you won't be in nursing school apparently, but if you get out and that is your dream job in nursing, you also right here referred to as sunny side up, because what's coming is baby's face is coming up out of the pelvis first instead of the back of the head. You're gonna see that I don't know how my baby came out. Well, I mean, I just know that it came out. I don't know. They don't let me peek over the curtain in the C-section. So as you can see in this picture, back of baby's head, so your occiput, that's the front of mom's pelvis. So that's how we want baby oriented. Okay? Any questions about that? This is just showing you feeling out of baby's head. So our sutures are not completely closed. Why do y'all think some of that is? So it can go through the birth canal. Also, we gotta allow for some growth. You have your fontanelles. They both should be open. They should both be soft. When baby comes out, your front one, your anterior is a diamond, your back one's a triangle. Roughly. With your finger. All right, so we put me on monitors. We have checked me. We know that baby is head down. We know that baby is occiput anterior, which is what we want. All of those things, okay? We've talked about this already. Oh, no abbreviations. So SROM, spontaneous rupture of membranes. Membranes, I can talk. AROM is artificial rupture of membranes. If they break on their own, they're spontaneous. If the doctor does it, then it's artificial. Okay? I did forget to say something. Along with color, amount, time, all that kind of stuff. What is one more thing, especially if they're in the hospital when they rupture? What do you think is one more thing we're gonna want to know if it came out along with when their water ruptured?
Maybe smell.
Hmm?
Maybe smell.
Hopefully there's no smell, but yes, odor would be one. An actual anatomy, like something that is anatomical, that has to do with mom and baby. What do we not want to come out? The umbilical cord.
Oh my God.
So that would be prolapse cord. We do not want that. That can cause fetal distress or fetal demise. So depending on because you have to remember, that's what's supplying blood flow to baby. So if that cord comes out and is prolapsed, it can either be, it can pull, because baby's flipping and flopping in there. Lots of babies come out and the cord is around the neck. It doesn't always mean that it's a horrible thing. We get it off quickly, they're fine. But if the cord prolapses and it's around baby's neck, it's gonna pull, okay? You lost your slack. The other thing is if it comes out and it gets compressed, then we're compressing blood flow to baby. So that's why we're just so worried about a prolapse cord. So in the hospital, they a lot of times will try to, if you're gonna get a physician, this part I've never been actual labor and delivery nurse, so I don't know where their scope of practice is, so I don't wanna say, you might have to get a physician, I don't know if the nurse can do it. They try to get it back in there and then we're gonna probably get baby, everybody delivered. So that might be an emergency section, go ahead and get them out.
If it's in the hospital, is the doctor that ruptures the membranes? So the doctor would see it.
The doctor would see it, okay.
So.
But again, I don't wanna tell y'all wrong, I do not know, and I don't know if it's a per policy, that I don't know enough to know if a nurse can assist, if for some reason the physician, like let's say mom's spontaneous ruptured in the room. I don't know if nurse can do that, I'll be honest, I don't know if that's part of, they probably, I don't know. All right, so we have 4 stages of labor. Your first stage is literally while you're laboring. So,
Just to back up really quick.
yes,
I know you said well, I don't know how to say the word, occiput. That. The anterior is good. If they're in the posterior, we can still deliver?
you can still deliver. It's a harder delivery for mom. She has to do more pushing, because think of it this way, if we're like this, the biggest part of baby is gonna come out first, and that's what we want. If we're like this, we're gonna have like this come out, and then we have to try to get under the pelvic bone and bring out the biggest part.
But there's nothing that you can do to get it into a different.
Depending on the physician, they may or may not try to rotate baby, but that is a physician thing, but they don't have to. You can deliver baby sunny side up. So your first stage of labor is literally just while you're laboring. Our time from 0 to 10 centimeters, okay? What ideally we would like to see is as you go, like when you're in the very beginning and you're just, a lot of people walk around at home in 0 to 3 centimeters. We may not have them in the hospital unless they are really having good, active, regular contractions, okay? Or if their membranes have ruptured. We really consider you active kind of once you get to this 4 to 7 centimeter range. And then 8 to 10 is when we're really transitioning. Baby should be really coming down and trying to engage in that pelvis. Mom is going to start feeling pressure to push. Sometimes moms can have nausea and vomiting at this point in time. I have not really seen, I know on TV, they make it seem, I'm not saying I haven't heard some dramatic screaming in labor, but I don't really see it like TV. It's not like they're, I've not seen it in the deliveries I have been in. But anyway, mom does get a little apprehensive. Biggest thing in here, if you were the labor and delivery nurse, you just want to be educating mom, talking to mom. How are you feeling? Reassuring her what is normal, okay? That's a normal feeling. That's an okay feeling. Those types of things, okay? Somewhere in this stage is, if mom wants it, is when we're going to get an epidural. Typically with a vaginal delivery, it's an epidural. With a C-section, it's a spinal. Does anybody know the difference? Epidural's all the way down. There is a catheter with an epidural. There is not a catheter with a spinal. The medicine goes in 2 different places, and we'll look at a slide in a minute. But with an epidural, you have a catheter, so you're continually being infused with medicine. A spinal, you do not.
So if you start with an epidural.
Typically, if you go to a C-section, if your epidural is still working and still in the right spot, a lot of times they just give it a really good boost to go to a C-section. Unless something has changed, they're not really going to take you in there because you're already numb. And trying to have you sit to do a spinal when you can't feel your lower half is going to be kind of hard. So just like with other things, when we have talked about pain and pain management, mom doesn't want to be medicated, great. We're going to do other things. We're going to have relaxation. We're going to have breathing. Again, they can do the water birth thing. If mom is not on any medication that would numb her legs, so an epidural or a spinal, and as long as mom hasn't really gotten anything that we're really super worried about a fall risk, and she's not dizzy or lightheaded or real sleepy, then mom can get up and walk and move around, distraction, all of those types of things. Some women want a doula. So a doula comes in and they're basically like their birthing coach. And that's fine. Most facilities allow that. There are things we can do outside of epidural and spinal. So there are some analgesics that we can give that are safe for mom and baby. I will say this, when I worked in the NICU, even if those were given, they still would let us know in the NICU because it's still an analgesic and there still is a chance that it can decrease baby's respirations. So we would kind of just be on standby just in case baby came out and needed a little bit of support to really get going. They can have Zofran for nausea. I have not been in a delivery yet that I have seen sedatives. If we need mom sedated, the only time I have seen is when mom was literally, so I had students, we went and there was a mom who was delivering twins. having a C-section. It was their first babies. It was a real kind of slow day, so had 2 students with me, and we went back to the C-section room. Mom delivered babies. Babies looked good. They couldn't get mom to stop bleeding. They couldn't get her uterus to firm back up. And they did everything they could. They gave meds. They did all surgical interventions. They had to convert to an emergency hysterectomy. They had to put mom out. So that's a time but we converted to full-on general anesthesia. I have not really seen, I'm not saying it doesn't happen, I'm just saying in the 6 years that I've been taking students to labor and delivery, I have never seen a barbiturate or a benzo given to a laboring mom. So I don't think it's as widely used as maybe it once was. But that's just really for practice, but they can be. A lot of times moms who want to go unmedicated, we're up here. A lot of times they don't even want these types of medications either. But again, that's why we ask them their birth plan. Let's see. Okay, so spinal versus epidural. So our spinal anesthesia goes straight in your cerebrospinal fluid. An epidural is a catheter in the epidural space that delivers medicine. Like we said, spinal, no catheter. Epidural does have a catheter. Spinal is mainly used for lower limb and pelvic surgeries, which would include your C-section. Your epidural can also be used for those same reasons, but is our primary mode in child delivery. And then if there is, mom is super high risk, if something comes up that, for whatever reason, they always have the option to put mom under general anesthesia to deliver baby. But like I said, that would have to be like real high risk. I can't really think of something off the top of my head right now, but that is also an option. And then, like we said, they can go completely unmedicated for a vaginal delivery. We're not going to let mom go. Mom's not going to want to go unmedicated for a C-section. So only vaginal are we really going to have the option to go unmedicated. What are some nursing considerations? Does anybody know what can happen to your blood pressure when a mom gets an epidural or a spinal?
It decreases.
Huh? It can drop. All right. So when I got my epidural with my first one, I'm sorry guys, I'm hot and I just can't be pregnant anymore. All of a sudden I was sitting there talking to my nurse and I was like, okay, all of a sudden, like, room got spinny. I was like, I just don't feel right. And about that time it cycled and my blood pressure had dropped. So she gave me a little medicine to get it back up. With an epidural, can you have moms that still feel things? Yes. Can it work better on one side of the body than the other? Yes. It is not perfect. By the time I was pushing with my first one, because he's the only one I've delivered vaginally, my others were C-sections, I could move my legs. So, I don't know if I had wiggled enough. They tried to boost it. It didn't do anything. It was fine. I still had enough in me that it was not unbearable or whatever, but I could move my legs. Are we going to let mom get up if she's had either one of these? No. When does mom get to get out of bed? When she has complete feeling of her legs again. Yes. All right. So second stage of labor. We're at 10 centimeters so we go into the pushing phase, basically. We're at 10 centimeters, we're pushing, and second stage of labor is until baby comes out. You don't have to go, we're not going to go through like the cardinal movements of birth. Like you don't have to have them like memorized and know what they are, but just know there are certain things that baby does. So baby's going to come down and get engaged, and we're going to descend into mom's pelvis. Baby is gonna flex to get up underneath the pubic bone. Baby should kind of rotate itself. Sometimes if that heads out, doctor helps with some of that rotation. And then baby continues on its way out. And so there are some things that baby does and moves to kind of come out, if that makes sense. So if baby doesn't complete those movements, and like I said, a lot of times once head kind of comes out, the physician can assist getting baby to do the rest, but then we may have to intervene, and we'll talk about those interventions in a minute. So like I said, you don't necessarily have to know all of them and exactly what they do, but just know that there are cardinal movements of birth, and that's how baby descends through the canal and comes out, and they have to do those to be able to come out. All right, why do we have moms push with contractions and we make them stop when they're not contracting?
Well, contractions, they bring the baby down.
Correct.
She pushes and she forces.
Correct. So we're gonna help mom work smarter, not harder, okay? So the contractions are our body's natural way to get baby to come down and out. So when we have mom push, we have her push with contractions to increase the efficacy of our contractions, okay? So mom can push in several ways. Now I'm gonna say, if we have had an epidural, you're going to be in a lying position or sit like they might sit the head of your bed up. You're not going to be over here bouncing on the ball. You're not going to, I don't think they will do water with an epidural. I don't know. I've not seen a water birth yet because you don't birth in water. So you have to be able to get out of it. If you can't feel your legs, do you think you're really going to be able to support yourself in this position? Probably not. And you're not going to be able to support yourself there either, okay? So, but they have lots of different things that can mimic, if you have had an epidural and you're in bed, to kind of mimic some of this. So they have the peanut. It literally is like this big rubber ball looking thing that's in the shape of a peanut. They can put that between mom's legs so that it kind of shifts her uterus and her pressure is being applied to kind of help. You can change positions like laying on a side, those types of things. If you haven't had an epidural, then you have other positions you can get into that are more either comfortable or might aid more in getting baby down. So there's lots of things they can do nowadays instead of mom just literally sitting in the bed pushing like we see in all the movies and what we typically think of. Which is another reason I wish I would go to labor. So, an episiotomy. So, an episiotomy is something the doctor does. So, we make an incision so mom doesn't tear on her own, okay? It is more controlled. It hopefully prevents more damage because a tear we can't control. So if doctor sees that mom is going to tear, we're not stretching, he's going to make a little, or he or she is going to make a little bit of an incision to create more space for baby to come out, okay? And then they will sew it up after baby's out. You can see down here, you can have anywhere from a 1st degree to a 4th degree tear. If you have a 4th degree tear, you are torn from front to back. They do stitch you up, but do you want to?
You still red from that match?
Yeah. I would not. We will talk about Forson's and vacuum in a minute. So some complications that you can have. We can have an amniotic embolism. What is that? Heart, lungs, yes. So just like an air embolism, a fat embolism, it's amniotic fluid that goes where it's not supposed to. Uterine inversion, so basically your uterus flips on itself. You can have a ruptured uterus. So, again, I'm just using myself as an example. after my first pregnancy, they sent me to a high-risk doctor. He basically said if you don't have your fibroids removed, you will never successfully carry a pregnancy again. So went and had them removed. Where my largest one was deep in my uterine cavity. So it created a very thin spot in my uterus. That's why I had to have C-sections from then on out. Because if I contracted, I was at very high risk to rupture my uterus. If we rupture something, we bleed. Not good. And then a baby can have a nuchal cord, or they can have a knot in their cord. Sometimes baby comes out and the cord may be around their neck and baby's just fine. They unwrap it once, baby's crying pink, the whole 9 yards. Sometimes they come out and baby can kind of be stunned because as they've come through, it's gotten a little tighter or it's wound again. Majority of the time, we get it off. Baby kind of is stunned but gets going and fine. There's pictures of knots in the cord. I have not seen that, but again, I'm not a labor and delivery nurse. So, and that's a picture of a prolapse cord right there. And then that's your nuchal cord. So think of this kind of like a hose pipe. If you put a knot in a hose pipe, do you get as much water coming out? No. So if we have a knot in our cord, we're not getting as good blood flow.
You still deliver with a prolapse cord?
You can. If they can get it back in there and they feel comfortable, they may continue the vaginal delivery. If they are uncomfortable with the whole thing, they're going to take them and do an emergency C-section. And that's a physician kind of call. All right, your third stage of labor. What is that? That's your placenta. So your third stage of delivery comes after baby's born until you deliver your placenta. Will be anywhere from 5 to 30 minutes.
Do people really eat that?
Yep. I think they put it. Some people put it in capsules, so then they swallow. Like anyway, whatever. So anyway, 5 to 30 minutes following delivery. A lot of times, other than the physician saying or asking mom if she needs to get a little push to get it out, a lot of times mom's distracted by baby and everything going out and has no clue that is what's going on down there when the placenta comes out.
Do you have to re-deliver it, or it just kind of falls out at that point?
It kind of comes out on its own. Sometimes they'll have to ask mom, hey, can you bear down or give me just a little push? And
They just kind of pull it out?
yeah. So a couple of things that you may or may not see if you become a labor and delivery nurse that's also part of birth plan is they will delay cord clamping if that's what parents wish. So basically what they do is they do not cut the cord until there is no longer a heartbeat in the cord. So they basically get as much blood and whatever out into baby, and then they'll cut the cord. So that's sometimes what you see, that typically if somebody doesn't have a preference, as soon as baby's out and we get going, they clamp and cut the cord. We're going to ensure that it's completely intact. So if we have any part of the placenta that is retained in the uterus, what would be 2 big things we would worry about? Infection, hemorrhaging. You're messing me up back there. It's like, wait a minute.
What was the question you asked?
If we had, we want to make sure the whole placenta is intact. If we had any retained placenta, what are 2 things we would be worried about? And that would be infection and bleeding. The other thing parents can do is they can donate the cord blood. They can either donate it and store it for their own child. So like if you had a child that developed a cancer, or if you have a sibling that developed a cancer or whatever, they can go and use their cord blood. Or you can do it just like when we go donate blood to a blood bank. You can just put it in a bank and then anybody could use your baby's cord blood. So some parents do that. So we're going to kind of switch gears for just a second. What is the purpose of the placenta? all words, but nothing, it was like Charlie Brown over the phone, wah, wah, wah.
She said nutrients, I said keep the baby alive.
Okay, both. Specifically, what is flowing from the placenta to the baby? Blood. How many vessels do we have in the cord from the placenta to baby? 3. What are they?
Wait, what did you ask?
How many vessels are in the cord going from placenta to baby? We want 3. You can get by with 2, but 3 is what is anatomically correct. What are those 3 vessels?
Vein, artery.
Say again. So you said 2 veins. What did you say back there?
I'm saying you at least need a vein and an artery, right?
You need a vein and an artery. So typically, if you have a 3 vessel cord, you have 2 arteries and a vein.
Do we need to know that?
Yes.
Is it gonna be on the test?
It is in your workbook. It is fair game for the test. Which is why I'm going over this.
Are you putting it on
I'm not telling you. So whereas Miss Bridges gets all geeked out about adult perfusion, I get a little geeked out about fetal perfusion and how all of this shifts from utero to life outside the body, if that gives you any.
That's the main thing.
Because I think it's really cool. All right, so we have 3 vessels, 2 arteries and a vein. What carries blood from mom, aka the placenta, to baby? The vein.
The vein.
So, right, vein carries blood from the placenta to the mom.
From the mom to the baby.
From the placenta to baby.
Yeah, but essentially from mom, yes, yes. And your arteries carry it back.
Wait, what?
It's so backwards.
Your umbilical vein carries blood from placenta to fetus. Let's make sure. That is. Let's make sure I did not type the note backwards, because I did look it up to remember that I was. And I didn't bring my big book up here. Actually, I think it's in this book. You know, sometimes we can make mistakes. Yes, okay. I wrote it right. Don't make me question myself. The umbilical arteries transport blood from the fetus to the placenta, so the vein carries from placenta to baby.
But it's oxygenated, even though it's vein.
We'll get there in a sec.
Right, so the artery carries it
From baby back to placenta,
so away from it.
away from baby.
Arteries go away.
Yes,
Okay.
vein carries it to baby.
Okay.
Okay, in you and I, where does oxygenation take place? In the lungs. Where does oxygenation take place in mother and baby and mother and fetus? In the placenta. The umbilical cord is what carries blood. Its sole purpose is just to carry blood from placenta to baby. Actual oxygenation takes place in the placenta. Okay? Do babies breathe in utero? Do their lungs open and expand and
Yes.
close like you and I breathe? No.
No.
No. Okay. So, let's do a little A and P up here. All right. So, Doctor, if y'all haven't done heart stuff, maybe she'll be so impressed that y'all are on top of this when we get there. All right, we have 4 chambers of the heart, right? Okay, so we have blood that enters the right atria through what? And you and I,
Superior.
what vessel is bringing our inferior vena cava? I heard IVC somewhere. Okay, so it comes in. Is it oxygenated or deoxygenated at this point? Deoxygenated. We go from the right atrium where? Right ventricle, and then from the right ventricle we go where? Say it again. There's some lungs. And we get oxygenated and we come back where? Okay, and now we're oxygenated, correct? And we go out to the body and we oxygenate the rest of it. Okay, but y'all told me baby's not breathing. We're not using our lungs. And you told me oxygenation takes place in the placenta. So do you think this is the path we follow in utero? No. So what do y'all think? Y'all think baby has some different structures? Not baby, fetus has some different structures so that we can oxygenate, we can take oxygenated blood to the rest of the body? Okay, yes we do. Good. Okay, so in fetal circulation, there are 3 shunts. So basically there are 3 holes that exist. I'm about to tell you because they're all different. All right, so your first one, I'm a nervous speller, so I'm going to copy it because I'll misspell right in front of y'all. Actually, I just am a sucky speller. So, all right, those are your 3 shunts. So, what vessel did we say brings blood from our placenta to baby? The umbilical what? Vein. So, it's your ductus venosa, V, vein. The 2 structures it connects are your umbilical vein and your inferior vena cava.
Wait, say that again.
So your ductus venosa, so V for vein, connects your umbilical vein. When I say connects, that's where blood flows through. Your umbilical vein to your inferior vena cava.
To babies.
Yes. Yes. This is all in baby. So then, now we have blood that comes from here to your, so it's like this. So umbilical vein, really crappy marker. So umbilical vein to there, from there, your inferior vena cava to our right atrium. So in us, you told me we would flow from right atria to right ventricle to the lungs. We're not going to do that in baby. We have another shunt that is right here, and that's your foramen ovale, and it connects your right atrium to your left atrium.
Wait,
Foramen ovale.
So they're not using their ventricles. So it's like bypassing their.
Well, this is at the
The right
moment.
one.
For the moment. There is one ventricle that will get bypassed. So then your ductus arteriosus connects our right ventricle, in my ugly writing we have up here like your aorta. So blood flows from your right ventricle to your aorta.
Next, your right ventricle to your aorta.
Alright, so we got umbilical vein. to
Yeah, it brings-
Ductus venous to inferior vena cava, the right atrium, and then
And then we
Through
go
the
from
frame of
right to
valve.
left, we kind of. Yeah, cause it comes in oxygenated, like we don't have to go somewhere to get it oxygenated, it's coming in oxygenated. We get it through the heart, we get it out to the body. And then get it out through the body, our aorta takes it out. And then when it comes back in the two umbilical arteries, we're going back to the placenta to get oxygenation again. So basically, remove your lungs and replace it with your placenta. That's where we're going to get oxygenated and bring it back. What I really want you to know is that these three shuts exist and what two structures they connect. Does that make sense? Okay? So you need to know that this is umbilical vein to IVC. This is right to left atria. This is your right ventricle to your aorta. That's what I want you to know. Along with knowing what brings oxygenated blood in and which vessels take blood back out. Yes, Alexandria.
Okay, the ductus venosus or whatever.
Yeah.
Connects umbilical vein to the IVC.
Yep, vein to vein. Umbilical vein to your, well, it says your vena cava, but remember all your V's, VVV.
And then the inferior vena cava brings blood into the right atrium, and the foramen ovale allows it to bypass into the left ventricle, which then pumps it out into the body through the
Left
whole-
atrium, not left ventricle.
Oh, left
The hole
atrium.
in the heart is right there.
well.
And
And that's it.
You go.
then it goes from the left atrium to the body. And then you're saying that the ductus arteriosus connects what?
Your right ventricle with your aorta.
So it goes from the left atrium to the right ventricle?
Fetal circulation. That's some weird things.
I thought it connected the pulmonary artery and
Fetal circulation is, so we are having very little blood flow go to the lungs. We have just enough for them to develop. That's one of the reasons they are the last thing in the fetus to develop. Because we're not using them, we don't need tons of blood flow. So we're not putting tons of blood flow through that pulmonary artery to get down into our lungs. It's literally just enough blood that goes there to develop them. Just know, our ultimate path is from
Shoved it through
umbilical
the ductus.
vein to our IVC. Basically, we're going from our right ventricle up to pulmonary artery to our aorta. So you have blood that's gonna come in, your blood's gonna come in. We have some that goes this way, we're gonna have some that comes down and goes back up this way, and then your other comes here and out the body. Again, what I want you to know, what do these structures connect? We will just say pulmonary artery to aorta. So that y'all are very clear on it.
So it's not left ventricle to aorta, like she was saying?
Left ventricle does go to aorta, yes.
Yeah, like it comes here and goes through and out.
So y'all just said pulmonary.
No, like you're correct, sorry, okay, let's start over. So
That's fine, I'm talking about the ductus arteriosus.
your ductus arteriosus goes from your right ventricle to your pulmonary artery to your aorta.
I thought it was.
Everything still goes out the aorta.
So it's not left ventricle like she was saying?
Part of it is.
So what would be the right answer on the test?
Both. So that's what, okay, so ductus venosa, your V's, your umbilical vein to your Got that. Your foramen ovale connects your right atrium and your left atrium. So your blood comes in here. You got blood, 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 blood. Some of your blood goes this way. Some of your blood goes this way. More oxygenated blood goes this way, and then we flow just like we normally do.
We're still going to the right ventricle because some of the oxygenated blood still has to perfuse the.
Like I said, we still give some blood to your lungs. So you have some that comes to your right ventricle, and then it's going to come up, hit your pulmonary artery, and then come out your aorta.
So ductus arteriosus, right ventricle to pulmonary artery.
No, pulmonary artery.
To aorta. But it starts, oh, so it can go to the right ventricle or the left.
Yeah,
ventricle.
right ventricle to pulmonary artery to aorta. This is right atria to left atria.
Got it.
So, when, we got all that down, when does the shift happen? From fetal circulation to regular circulation? And they're born, not from beginning. What happens to those shunts? They close.
So shunts close at the same case
They should. So, and sometimes they don't close immediately, sometimes they may take 24 to 48 hours. Some not closing are worse than others. So, if a baby is born, and so like my second child, he was born when a pediatrician came to see him in the hospital, they heard a murmur. They're gonna get a heart echo that comes in that looks at everything. One of his shunts was not completely closed. It was a very benign murmur. By the time he had his first pediatrician visit, it was gone. So they kind of look to see if there is a murmur, what shunt is still open. And then we want to follow up and make sure it closes. If they don't close, they will eventually have to, a lot of them will require surgery to close it. And it all has to do with pressure changes. So lungs open, pressure shifts, that's what closes those shunts and gets lined open. Any questions? Probably lots. It's not clear as mud, or it's clear as mud, I'm sure. Y'all think on it, email me questions. We'll talk about it again next week because we talk about newborn again, so we'll do that. All right, your fourth stage of labor is 1 to 4 hours after birth. Mom is starting to have like physiologic, her body is readjusting back to pre-pregnancy states. Usually we see blood pressure come down. We might see an increase in heart rate. Her uterus is contracting, or it should be. If it's not, we're in trouble. Mom can be thirsty, can be hungry. A lot of times, other than ice chips or very small sips of stuff, we keep mom NPO just on the off chance that one, they can get nausea and they can vomit, but two, on the off chance that we have to go for a C-section or anything like that, we kind of keep mom as close to NPO as possible. Shaking can be for lots of reasons. They can shake with their epidural. And some of it is just we've been kind of in fight or flight while we've been laboring, and we're kind of, our body is kind of coming back in. So you may have mom that's kind of shaking. Things that we're going to immediately assess is their fundus, which is what? Top of the uterus. We want it to be firm and we want it to be in the midline. If it is soft or boggy, then we are at higher risk for mom hemorrhaging. So we're going to fundal massage, and we're going to get that uterus to contract. So, because as it's contracting, so your uterus is a muscle. So during labor, we want it to contract because it's going to help squeeze baby out. After birth, we want it to continue contracting because it's squeezing and clamping down, which is stopping that bleeding. Okay?
I feel like massage is very generous.
You're going to check mom's bladder. If mom's bladder is full, it's gonna displace the uterus. If the uterus gets displaced, it bleeds. So if you go to feel that fundus and it's not in the midline, it's off to one side, or then one of your immediate thoughts should be, let's check mom's bladder. Has she peed? Do we need to cap? If we still have no feeling in our leg, do we need to cap mom? Just do a straight cap and empty that bladder. If mom has feeling or didn't have an epidural, let's get her up and get her to go to the bathroom. We're also going to be checking her perineum area. So did she have an episiotomy or did she tear? We're going to kind of look at that area. Lochia, that is the fancy term for discharge from mom's vaginal area. Right after delivery, what color do you think it's going to be?
Red.
It's going to be red. And we'll see next week. We'll go through the stages of it. It will change. But immediately after birth, it's going to be red. Typically, if there's probably going to be some clots, that's fine. We don't want anything that is super huge, humongous in the way of clots, or we don't want numerous clots. Some is okay, but not too much and not too large. And kind of the rule of thumb, if mom is filling up a pad an hour, that's more bleeding than what we want. We're also going to assess pain and vital signs, and then we're going to encourage bonding. So as long as mom and baby are both hemodynamically stable, then baby is going to be on mom. We're going to be skin to skin, okay? Sometimes during this first little bit, baby will go ahead and want to nurse. If mom's going to breastfeed, and sometimes baby will wiggle their way down. They know where smell is coming from, where food is, and they'll wiggle their way down there. So if baby and mom want to go ahead and nurse, we facilitate that. But baby is skin to skin because that helps baby regulate temp, their blood sugar. It helps mom's vital signs return to normal. There is so much as far as study that has come out on the benefits of skin to skin. So we do that as quickly as possible, assuming mom and baby are stable. All right, so immediately in the delivery room, we're going to go through APGAR. Who knows what an APGAR score is? Yep, so it is a baby assessment. What are we assessing? So each letter stands for something. So A is for activity. P is for pulse. G is for, it's really grimace, but really that we're not looking at like necessarily baby's facial expressions. We're kind of looking at baby's overall body, tone, and posture. Appearance is skin, color to be exact. And then R is respirations. I will go in depth into that next week. You will have a question about APGAR scoring on your test.
Just one question.
I'm going to keep mental note of all this.
What was R?
R is respirations.
What was G again?
Technically it's grimace, but it doesn't mean like baby's facial expressions. It's literally like the overall tone of baby and their body. Like, are they floppy? Are they, like, we want baby all curled up. Baby's been like this in utero. So we want baby to have good tone, that kind of thing. Most of the time, in the delivery room now, mom has a nurse, baby has a nurse. So you have your labor and delivery nurse, and then you have every hospital may call them different, nursery resource nurse, whatever. But you have a nurse that comes in right at delivery. Her whole job is just to take care of baby. She's the one that does the APGAR, she weighs, does all of that with baby. And like I said, we'll go more in depth into baby next week, but they're going to do a quick assessment, part lungs, we're going to take baby's temp, we're going to get baby dried off and get baby back on mom's chest. A lot of what we can do to assess baby, we can do while baby's on mom.
Unless there's.
All right, so we kind of talked about this a little bit. The biggest thing we kind of worry about after delivery is hemorrhage. We want, uterine apnea talks about the tone of the uterus. We want that uterus to be firm. things that can affect it is mom has prolonged labor. Again, your uterus is a muscle. So the more you use a muscle, the more tired it gets. Sometimes if we induce labor and the body's not completely ready, sometimes we see more hemorrhage after an induction. If mom has a prolonged third stage, what was third stage? What do we deliver in the third stage of labor? Placenta. So if that placenta stays in there longer than what is expected, we already talked about retained placenta, and then we talked about bladder distension. Mom can also develop a hematoma. A lot of times you will see that at the site of their episiotomy or if they tear. And then we have to kind of be careful of any lacerations that could be internal or external. So if precipitous delivery, so mom delivers really fast. So it's like we come in, mom goes, from 3 to 10, and out comes baby in no time. Sometimes you have more tearing and more trauma from that. We have to use forceps or a vacuum. That can cause lacerations. Or if baby is really big. So that's what macrosomia is a baby that's large for gestational age.
How long is prolonged?
So your typical, you want that, are you talking about prolonged labor?
Prolonged labor. Are we talking about like hours or like, I don't want to say days, that's terrible.
It does sound terrible. I would, well, it kind of depends on the pregnancy. So your first, you expect mom to labor longer with her first baby versus a third baby. Because by the third baby, your body kind of knows what to do, kind of is more efficient in doing it. So it kind of depends on which pregnancy we're in, and the person, there's not like a specific after 4 hours of labor we're prolonged. So I would say definitely if we're kind of getting in that we have been in, and I would say it's active labor. So not like that latent phase or early phase where we're having mild contractions. Like we're in active labor, or I would say probably more than 24 hours. So with my first one, I went into labor about 8 o'clock that morning. I had him about 8:30 that night. So probably when I first started, I was consistently contracting, but I was like 4 or 5 centimeters dilated. So my active phase was longer. I only pushed for an hour. So let's say we're kind of much longer than a day. That's when we kind of get worried. So nursing care during labor, we're going to get informed consent. Again, mom's going to be NPO, other than they can have ice chips, and now they kind of let them have little sips of water or something like that, but nothing big. Popsicles. Lots of advocating and education, okay? So like I talked before, especially if you have a first-time mom who's not done this, you really want to tell her, this is what we're doing, this is what you can expect, this is a normal feeling, all of those kinds of things. Like it would have been a little bit nice for that nurse to tell me the first time I got an epidural to expect that I might get a little bit dizzy and lightheaded because my blood pressure dropped. Well, she didn't, and all of a sudden I'm feeling really weird, and I'm like, what's about to happen? It would have been nice to have known that ahead of time so that I was prepared for it. We are also, when they come in, we're going to assess their contractions, the fetal heart rate, their pain, vital signs, all those things that we've already talked about, okay? If they have to have a C-section, majority of the time what you're going to see is this flow transverse incision, but they can have, this used to be, that's why it's classical, that's what used to be seen. now, this is your more common incision. I don't know if this is still the rule of thumb because you don't really see this very often. I know it used to be harder to do a VBAC, which is a vaginal birth after a C-section, if you had a classical incision versus your low transverse because of where they made the incision on the actual uterus, okay? Where you're cut on the outside does not indicate where they cut on your uterus on the inside. Does that make sense? Some reasons why you might have a C-section. So, baby is not in the right position and we can't get baby to turn. If mom has an active genital herpes infection, we're gonna have a C-section, so we don't transmit to baby. We've already talked about a cord prolapse. If there's any kind of fetal distress, we want to get baby out as quickly as possible. We're gonna do that with a C-section. The other thing, if mom has labored for a while, and sometimes they kind of know this ahead of time, but a lot of times they give mom a chance to labor and see what happens. If you have mom who has a very small pelvis or a pelvis that does not expand, and you've got a baby with a really big head, it's not gonna fit. So sometimes if you have disproportion, then mom has to have a C-section. So those are some of your biggest reasons why you would see them. And depending on the reason for the C-section, if mom gets pregnant again, then sometimes she will have the option the next time to have a vaginal birth. Just depends on the reason for the C-section. Again, just like we talked about last semester, this is considered an OR procedure, so kind of all your things that have to do with pre-op and all that you learned with Ms. Bridges apply. We're gonna have a consent, we're gonna have an IV. Mom is gonna get a Foley. Typically they put it in after she's had her spinal, so we're not feeling that. She's gonna get prep with abdominal prep, they're gonna drape, all of that kind of stuff. Whoever her care partner is, so whether it's spouse, significant other, whoever, grandparent, they can come in to the C-section while they're in there, and they'll be garbed up like the doctor. So, we talked a little bit, so we can induce labor. So, most of the time now, they won't let mom go much past 40 weeks because they have learned that there's actually, we have risk if baby comes too soon. Well, now we have risk if we let baby go too long. So mom starts to lose fluid. We see higher risk of infection and other things like that. So if mom gets to 40, 41 weeks and the body is not kicking into gear, we can kick them into gear. So we will induce labor. A lot of times they will put them in overnight. They'll bring them in the night before, and they might give mom a medicine called Cervidil or Cytotec. Cervidil is vaginally, and it starts to soften the cervix. It can do a little bit to induce contractions. Cytotec are pills that you can take that do the same thing. Cytotec is more potent than Cervidil, but they basically do the same thing. They just really get that cervix to start softening and thinning, and then they also can induce contractions. Typically they do that overnight. The next morning they kind of see where mom is, and then they're going to get Pitocin on board. So our body naturally makes oxytocin. That's what's going to get labor going in our body naturally. We can give it to mom synthetically, and it's going to stimulate the smooth muscle of the uterus, so it's going to make it contract. It's given IV. Once you start mom on this, so in the hospital a lot of times they say mom's on PIT. That's what they shorten it to. Mom and baby require monitoring. So mom's going to be on continual fetus and maternal monitoring if she is on PIT. We also, so let's say mom comes in labor, and we didn't have to induce her, she comes in labor on her own, but let's say we're somewhere around 6-7 centimeters and contractions just are not getting us any further. They can start PIT to make those contractions stronger to finish getting the mom to 10 centimeters. Hospital protocols are different regarding this. You can only go up so much every so often. You want to, anytime, we always want to document as nurses, but with things like Pitocin, and then if you have a patient that's on a MAG drip, and we'll talk about that in just a second, you want to document. Cover yourself to the nth degree, okay? Because while they're wonderful meds, they can cause issues if we go up too fast and too soon and different things. Or with MAG, we can see that if we give too much for too long of a time, we can actually harm baby. So we kind of talked about this. So a VBAC, vaginal birth after cesarean. It used to be that if you had a C-section, you always had to have a C-section. That is not always true. Moms have to be told that we will, and again, it all depends on why we had to have a C-section. If I still could have children, I would always have to have a C-section because of my reason for the C-section. But let's just say mom labor stalled or whatever, then the next time we can try and see if it works, okay? But mom needs to know that just because we're trying this does not mean we won't end up with another C-section, okay? So they always need to know that is the backup plan if this doesn't work. But most of the time, moms are successful. My sister-in-law had a C-section with her first one, and her second one, she was able to deliver vaginally. So the other thing we can do is we can use a vacuum or forceps to extract baby. So this is a little vacuum device. These are your forceps. So a lot of times if baby is just not kind of getting all the way down, or if mom tires out. So then the doctor will use these devices to kind of assist getting baby the rest of the way out. We try to avoid as much as possible with these devices. But they are ways, and most of the time they are used because of maternal exhaustion. So she has pushed and pushed and pushed, and she's too exhausted to keep pushing. And baby is just right there, so we use them.
So they still use it?
Yes. It is not, like I said, they're gonna do everything they can to get mom to push and get baby out. But no, if they have to, they will use them. So you can kind of see this baby over here, he had forceps. And you can see kind of left a mark and some bruising. I've seen some pretty bad bruising from forceps. Baby was fine, baby was not. It just looks bad. I've seen a baby that ended up with kind of like a hematoma on their head from the vacuum device, and the body just reabsorbed it, and we didn't have to do anything. But they do come with their own risk. So like I said, it is literally like last resort. Mom is completely exhausted, but baby has to be fully down and engaged. We're not going to go up there and baby be at like a -1 or a +1 and grab baby. Baby's got to be down right there where we're seeing the head, and we can kind of get to baby to finish pulling out. Real quick, as I mentioned it, you really will talk more about this when you talk high-risk pregnancy next semester. But you might have mom that comes in and needs a magnesium drip. So we do magnesium in pregnancy for 2 different reasons. Does anybody know what those 2 reasons are? Preeclampsia is one. The other one is preterm labor. What does mag do to smooth muscle?
Relax.
It relaxes it. So if we're in preterm labor, we are relaxing that uterus to get it to stop contracting. If we are on the eclampsia side, we are giving it mainly to help prevent seizures. Again, we're kind of relaxing smooth muscle, hopefully some of it getting that blood pressure down and preventing seizures. Because that's one of the big things we worry about with preeclampsia and eclampsia is seizures. With MAG, a lot of times when patients are put on MAG, they are like a one-to-one patient. They're staying there. We can only give so much MAG for so long, because if we give too much or we give it for too long of a time period, it can cause birth defects and other issues with baby. So there are very strict parameters around using MAG. Last question, and then we'll be done for the day. What are some, I hate to use the term nursing diagnosis, but I'm going to. What are some nursing diagnoses or priority concerns in a labor and delivery patient? They can be like, don't overthink. So yeah, blood pressure could be something that we watch for. Think more.
Is this during labor?
During labor and delivery. That's a medical diagnosis. Nursing diagnosis. Like, what are things that we as the nurse would identify as a potential problem or an actual problem that we can intervene with? That's what a nursing diagnosis is. So risk for bleeding.
Impaired gas exchange.
Are we really worried about impaired gas? I mean, it could happen, yes, but it could, but that's not one of right there at the top of the list. Because typically, you're taking care of a healthy patient. We're only there for delivering a baby.
Pain level.
Pain, acute pain.
All risk.
We've already said infection, we've said bleeding. With bleeding, what are we losing? Volume. So F&E, what are we? Fluid volume deficit. What would be one that is related to education? So if this is a first-time mom, she is needing what?
Emotional support.
She needs emotional support. She needs education about the labor process. So one could be deficient knowledge regarding the labor process. And then we're always worried about maternal or fetal distress. One thing I did, because I think I accidentally skipped it when we were talking about stations and all that. Now that we're talking about that. Yep, here it is. Okay. So, fetal heart rate monitoring and contractions. Your top of your strip is always your fetal heart rate. Your bottom are your contractions. Okay? I'm not going to teach you to count all of this. To me, that's very specific to if you want to go be a labor and delivery nurse. Not everybody in here is going to be a labor and delivery nurse. That is on-the-job training. Now, whoever teaches your high risk, if they want to teach you that next semester, that's on them. I'm not requiring you to know that for me. I do need you to know your top line is baby, that's your fetal heart rate, your bottom line are your contractions. The better the little mountain or hill on your contractions, the stronger they are, the closer they are together, the more frequent they are happening. And so you count from hilltop to hilltop. For a baby, we want to see all of these squigglies and the ups and the downs and all of that. That is called variability. We want a baby to have good variability, okay? We want, because that means baby is active, baby is reacting to labor. We don't want to see a heart rate that just stays right here along the same line the whole time. That is concerning for baby. These little mountains or hills that go up, those are called accelerations. So baby gets excited or is reacting to a contraction. We want to see that. What you can also see sometimes with contractions, and they're not always a bad thing depending on what they do, is you can see a deceleration. So see this little dip right here? So baby's heart rate went down. Sometimes that is just due to cord compression with the contraction. It is fine as long as baby comes right back up. What we don't want to see is we don't want to see a lot of these, and if we do see them, we like to see them in conjunction with the start or the peak of a contraction. We also don't want to see a real big deceleration or a prolonged deceleration. That is indicative of fetal distress, okay? So if we're seeing lots of that go on, this mom is probably going to be taken back for emergency C-section where we get baby out, okay? So for your test, know which is fetal heart rate, which are contractions, what is variability, and that's we're seeing, we don't have like kind of like a straight squiggly line. We have a line that goes up and down, up and down. No acceleration, the heart rate goes up. Deceleration, the heart rate comes down. Prolonged deceleration is bad, or frequent decelerations are bad. Any questions about fetal heart rate and your strip? You can see a strip on your test, just FYI. Again, you don't have to count the boxes. I'm not asking you to figure out fetal heart rate. I'm just asking you to know what we have just talked about.
So if it's on the exam and we don't see any hills or mountains, then we would.
Yeah, if it was just
Bad
this,
answer.
see these little, the little squiggle, if it was just a little squiggle that just do, that's not good. That is a lack of variability, and that is not a good sign. So if I ask you, does baby look good and healthy? Like, is this a positive looking strip or is it a negative looking strip? If it was just kind of not a straight line like a systole, but a straight line in that you have the wiggles, but you don't have the hills and the valleys, then you're going to tell me that's a negative looking strip. That's an ominous looking strip. Baby's not. That's not what we want to see. Baby's not reacting to labor.
Do we call the healthcare provider?
Oh, yes. Yes, we do. Now, sometimes they might shift mom. Let's see if we move mom, like get a hip up, something like that. Is mom in a position that we're not getting good blood flow to the cord? So initially it might be we just turn mom on her side, see if that variability improves. If it does not, then yes, we are definitely calling a healthcare provider. Any questions about any of this today? If you think of any, email me. Next week we will do postpartum and newborn and a little review.